Good morning. This is a rare case of retinal vein occlusion in a 16-year-old. As we all know, central retinal vein occlusion is commonly associated with the elderly. Occurrence in young patients presents a unique set of challenges and diagnostic considerations. So we had a 16-year-old girl who came to our OPD with chief complaints of left eye, sudden painless loss of vision since 3 days, was not associated with any other symptoms. There's no history of trauma. There was no previous systemic or ocular medical history. There's no significant family history. On ocular examination, right eye showed visual acuity of 6/6, anterior segment and fundus was normal, IOP was within normal limits. Left eye visual acuity was 2/60 with no improvement with pinhole. Anterior segment examination was normal, there was no RAPD. Intraocular pressure was within normal limits. Left eye fundus showed blurred disc margin with hyperemia, with dilated tortuous vessels and flame-shaped hemorrhages and cotton wool spots in all 4 quadrants. And a left eye OCT was done, which showed cystoid spaces and increased accumulation of intraretinal fluid, which was suggestive of macular edema. BP was within normal limits, and general examination and systemic examination was normal. Further investigation was done. Complete blood count showed decreased hemoglobin, and ESR and CRP was elevated, and increased homocysteine level was noted and was referred to a physician, and the renal function test showed increased urea, creatinine. There was an electrolyte imbalance and albumin traces were found in the urine. Ultrasound kidney showed bilateral multiple cyst with hemolytic content. So we came to a diagnosis of left eye central retinal vein occlusion associated with autosomal dominant polycystic kidney disease. Ocular intervention that was done was 1 dose of intravitreal injection bevacizumab was given along with folic acid supplements and was immediately referred to a physician. And a physician had started on iron calcium supplements, hepatitis B injection was given, and diet restrictions was advised. Patient underwent AV fistula and was advised renal transplantation. The patient was followed up 10 days after injection bevacizumab, and left eye visual acuity showed 6/18 powers with no improvement with pinhole. The left eye fundus showed exudates in a macular star pattern suggestive of reduced macular edema, and OCT showed reduced macular edema. So the review of literature suggested that the prevalence of retinal vein occlusion increases with age, whereas the pathogenesis and risk factors in young patients are still very unclear. So for a few studies show that hypocoagulable state was responsible for the central retinal vein occlusion with these causes. And one study which was done in 2000 showed that increased plasma homocysteine level is increased in diabetic patients but are more related to reduced renal function. A study done in 2007 showed that the venous occlusion may be a part of generalized vasculopathy associated with autosomal dominant polycystic kidney disease. Another study showed that pathogenic mechanism for end-stage renal disease includes vascular endothelial dysfunction, and arteriosclerosis contributes to the renal vein occlusion. And a study done by Rothman showed that the number of anti-VEGF injections was lower in young patients than in elderly patients. The patient was followed up 1 month later, and the left eye best-corrected visual acuity was 6/6 powers. So the take-home message is that unusual presentation of CRVO in young patients should always be investigated. This might always require a multidisciplinary approach, and the patient should undergo a genetic counseling and regular monitoring.
Thank you, Dr. Nivedha. Can you just tell polycystic kidney, how is it related to homocystinuria? Decrease?
It's increased homocysteine level.
Oh, I'm sorry, yes. How does this correlate? Is there a correlation between the both? Because the patient had hypercoagulability state because of homocysteinemia
yes,
increased. So is there any correlation between polycystic kidney and?
The renal disorders are generally associated with increased homocysteine levels, ma'am, but here the patient was diagnosed with autosomal dominant polycystic kidney.
So both are independent of each other? She had no hypertension, as you said.
No, she had no hypertension.
So both are independent of each other?
But she did have...
All right, it's fine, it's okay. So...
Usually after ruling out diabetes and blood pressure, of course in elderly and in young patients could be so many other reasons, autoimmune as well. So one very common thing which used to be pretty common earlier, not now, was a variant of eels actually, papillophlebitis we used to call it. So a trial of oral steroids, if everything else is normal, that would actually at times just resolve the condition, and it finishes off the CRVO picture. It could be because of an eels-like picture so many times. It used to be quite common earlier on, but now because somehow the eels has gone down, so even this picture is not very common now, but this is one possibility to be kept in mind.
What was the final vision gain?
6 past now.
So just as we used to call it non-ischemic type of a CRVO, but of course the homocysteine is high, polycystic kidneys, so she had so many other problems associated, which was incidentally